Here's a question I've been thinking about lately. Coping skills can be very helpful at times, but sometimes a coping strategy that helped at first gradually starts getting in the way of the changes the client was hoping to make. How do we know when that's happening? I teach graduate psychotherapy, and sooner or later we work through a case and reach the point where it's time to think about what to do next. More often than not, someone says, I'd teach a coping skill. That's not a wrong answer. In fact, it may be a helpful answer. But for me, that's where the interesting part of the discussion begins. So I ask a few questions. Which coping skill? Why that one? Why with this client? Why now? What are you hoping it will accomplish? And before we go much further, I ask another question. What is the client hoping will be different because they came to therapy? If we aren't clear about that, it's hard to know whether any intervention is moving us in an appropriate direction. Sometimes one intervention is enough. Sometimes we need several. Sometimes they work best together. Sometimes they need to be introduced one at a time. Good therapy isn't just about collecting techniques. It's about deciding what fits this client at this time and helping the client move toward the changes they hope to make. At this point, a student will sometimes smile and say, Dr. Steve, you're making this much more complicated than it needs to be. I usually smile back and say, actually, I'm trying to apply Occam's razor. The goal isn't to make our thinking more complicated. The goal is to make it adequately complex. If we ask too few questions, we may miss something important. If we ask a lot of questions that don't help us make a better decision, we've made things more complicated than they need to be. The challenge is asking the questions that matter the most. Now, let's come back to coping skills. Many coping skills are potentially quite helpful. They may reduce distress. They may help clients settle enough to think more clearly. They may make it easier to solve problems. They may help clients stay engaged in therapy. Those are meaningful benefits. But here's an important question. Can the function of a coping strategy change over time? I think it can. Imagine a couple who learn to take a time out when an argument begins getting out of control. Early in therapy, that may be exactly what they need. Instead of saying things they'll later regret, they step back, calm down, and come back to the conversation. That's progress. But suppose 6 months later, every difficult conversation ends with a timeout and the conversation is rarely resumed. The timeout still lowers distress. But is it still helping the couple move toward what they came to therapy hoping would be different? Or has it gradually become a way of avoiding difficult conversations? Or think about grounding. Grounding can be very helpful when emotions become so intense that meaningful work is temporarily difficult. But suppose grounding is now used every time uncomfortable feelings begin to surface. Has the coping skill changed? No. But perhaps its function has. Those are different questions. That's why I think it's important to ask not only whether an intervention works, but how it's working now. The data are changing throughout therapy. The client changes. The situation changes. Sometimes even the client's goals become clearer or need to be revised. So our thinking should continue to change too. For me, that's part of good clinical reasoning. It isn't something we do once at the beginning of treatment. It's something we keep doing throughout therapy, and we don't do it alone. The client should be a very important part of that conversation from beginning to end. Treatment planning shouldn't stop after the intake session. Together, we continue asking, are we still working toward the right goals? Is this intervention still helping? What are we seeing that supports that conclusion? What are we seeing that makes us question it? And sometimes we need another therapist to help us think. We're all vulnerable to confirmation bias. We naturally notice evidence that supports our current understanding more quickly than evidence that challenges it. Consultation and supervision help us ask questions we may not think to ask ourselves. One of Marie Bowen's questions has stayed with me over the years. Why this symptom in this system with this person, in this setting, at this time? I think we can ask something similar about ourselves. Why this coping skill with this client at this time toward the changes the client hopes to make? For me, those questions aren't about becoming more complicated. They're about becoming more thoughtful. None of us gets this right every time. I certainly don't, but I hope I'm asking better questions today than I was 20 years ago. I think that's one of the habits that distinguishes more thoughtful therapists. Not that they always choose the perfect intervention, but that they keep asking whether the intervention they're using is still helping the client move toward the changes the client came to therapy hoping would be different. I hope you found this video interesting. If you did, I would appreciate hearing from you.